Next speaker is Dr. Sreeni. All of you know Dr. Sreeni. He's the chief surgeon and the medical director at Malhari Eye Care at Talasheri in Kerala. Brilliant surgeon, high volume cataract surgeon, and I've heard him saying in previous talks that he doesn't have time for expansion devices. So he will talk to us about how to manage phacoemulsification without pupil expansion devices. Over to you.
Thank you. Thank you, Satish, for including me in your IC. Satish is one of the best persons that you can ever be with. Me, Satish, and Prince did our residency together at RPC. And see, this is, I'm not sure if I should be showing this, but Satish asked me to present on this, so I picked up some videos. Is that moving? Yeah. So this is the pupil that I had. Should you be doing surgery without pupil expanders here? So I decided to do it. So it's about 2-3 millimeter, but the rexus, even if it is this small, has to be at least 5 millimeter. So you go on to, I'll show how to do the rexus in the next videos. I would never dream to do phaco in such a small pupil if it is a very soft cataract. If it is a nucleus which can be chopped, I will go ahead with it, because if you can actually divide the nucleus in the pupillary area and take a piece out of it, then the surgery is quite okay. I mean, even with a pupil is so small. So there are two steps which are really critical here. One is the rexus. The rexus, if it is not big enough, or if it runs out to the periphery, then that's the end of it. So you have you have a separation, then you can finish the surgery. As Satish said, the reason why I at least go for phaco in these cases, because I have it might be the ego or whatever, a feeling that putting iris hooks or pupil expanding device would take more time, but finally you end up taking almost that much time when you are doing surgery in such a small pupil. So once a chop is done, then everything is fine. You can finish up the surgery. Then there are two other problems here. See, are you going to be able to wash off the cortex properly in these cases? I go for either bimanual or Simcoe. I mean, I'm quite comfortable with Simcoe. And when you're putting the IOL in, the leading haptic has to go into the back. Otherwise, you will have trouble. And keep on looking for small nucleus beds that might be hiding behind the iris and all. Otherwise, later on, you'll have. So this is not that small. So it is. You can pardon me for doing phaco in this. So I'll just show. See, always stain the capsule. Go for a larger rexus, you go under the iris with the rexus, then come in, under the iris, then come in, so that the rexus is a bit larger than this pupil. Don't just go in and lose a rexus. So that is okay. And I normally go for a cortical cleaving hydrodissection. Here also I went for that, but the previous case, I went for multiple quadrant hydrodissection. So here, again, just the same. This is a much clearer video because it's a big, larger pupil. So here, you have a chop, then that's it. It's quite simple. You have a good rexus, good hydro, good chop, pupil this size, definitely doesn't require any pupil expanding devices. The previous one, maybe it required one. So here it actually saves time. You can. I definitely wouldn't use a pupil expansion device or iris hook in this case, because this pupil is good enough. So what about the settings? So the vacuum I don't decrease, but the bottle height and the flow I reduce, so that there is no fluttering of the pupillary margin, and you don't accidentally catch the iris in the phaco tip. So this is it, and say everything goes on well. Again, for the cortical wash, again you can go for a bimanual, or what I actually do is if it is a 2.8 mm keratome, I just enter half only. It's a 2.4 even. So I have sort of measured it, and it comes to about 1.4. The normal side port for a bimanual comes to about 1.2. So it's the incision, the side port size is not that huge. And here the leading haptic has to go into the bag, and you have to make sure that the IOL is in the bag. So that is how I do it. So this is another case. Tried Phenokian there. Phenokian is the trade name, so no financial interest there for me. So again, just showing the rixes. It's not within the pupil. Just go under the rixes and bring it in. So that it's I look for a rexus of at least 5 mm. Here, trying to chop, and it's not really happening, and it's not really rotating. So leave your ego. Then in those cases, in between you can put an iris hook. So that is what I did with this case, and there was nothing wrong there. So this had a pupillary membrane. I normally, when you remove the pupillary membrane, the pupil becomes large enough. I normally don't go for stretch pupilloplasty in this, because it didn't enlarge enough. Because when you go for a stretch pupilloplasty, you might get the iris in the wound here. So this is one care that you have to take. Like you should not go near the pupillary margin. You will catch the iris. So once you catch the iris, I was lucky in this case, it didn't keep on coming. Once you catch the iris, then it will keep on coming. So don't go near the iris. And this was a small pupil. Everything went off well. The patient has 6'6", but post-operatively the patient had high IOP, recurrent pigment dispersion. So you could see that the whole IOL is in the back, but one haptic is out. And that was pressing on the posterior surface of the iris and causing pigment dispersion. And I had to go back in. Here again, no egos there. Put the iris hook and put the IOL, the haptic back into the bag, and within 1 month's time, I could see that it's gone into the bag. So should you go for something like circuses without any pupil expanders? I'm not sure, but you might end up doing that because you feel that it'll save time. But Matthew would say use expanders, right?
No, actually, I prefer not to use expanders unless it is absolutely needed. But as I have grown older, my adrenaline levels have come down a little bit, and I prefer to give. My first choice is the BHEX now. I use iris hooks a lot less frequently, and my decision making on whether to use a pupil expansion device or not is largely based on not just the size but the floppiness. So if I have a rigid 4 millimeter or a 4.5 millimeter, I would probably go without device. But if it is a 5 millimeter floppy iris, I would certainly say let's not take the risk, because once you chew it, it just needs 1 millisecond of lapse of concentration, you chew it and then it's done. So floppiness, not just the size.
So you, even if preoperatively you don't realize, you enter, you understand that it is floppy, then you put.
Yeah, all my cases, irrespective of the pupil dilatation, there is standby all devices, iris hooks and viscoat and the BHEX.
Just a quick question for the panel. Just say you don't have expansion devices or you're not skilled or you haven't learned how to use them. You still have a small pupil and you have to manage it. In your opinion, phaco versus SICS, if you're proficient in both,
Phaco.
which would be better and why?
Phaco. See,
Why?
See, obviously you need, I mean, if it is 4.5 millimeter excess or 5 millimeter excess, you can, phaco is fine. If you don't have a large enough excess and you manipulate, you do a hydro, I mean, you might find the nucleus down in the vitreous there, or you'll have the whole bag coming out. I would always go for a phaco if it is a small pupil, if you don't have a pupil expansion device. I think you need more skill for SICS maybe. I don't know.
Yeah, I sort of agree there. I have de-skilled myself. My first instruction course way back in 2008 at an international conference was on SICS, but then subsequently I have de-skilled myself, become more proficient at phaco and lost a lot of my SICS skills. So I would say yes, if you have the skills and the other equipment, phaco is probably better than small.